want to welcome you all for our first CEMA specific webinar. And the topic is Advances in PCIOLs, How to Become a Premium IOL Surgeon, with Professor Nikica Gabrić, PhD, and Dr. Ivan Gabrić from Croatia. I'm very glad that Professor Nikica Gabrić and Dr. Ivan Gabrić take time to present us their experiences of PCIOL. Professor Gabrić is placed in Zagreb and is the owner of the Svetlost clinics in different places in the Balkan area. Svetlost is also a clinic of the Rijeka medical faculty. And Professor Gabrić has a huge experience in all different PCIOLs. I'm really honored and proud that Professor Gabrić was one of the first users worldwide energy lenses and has done successfully till today approximately 400 patients. And to hear about his results here today. So, welcome Professor Gabrić, and thank you Dr. Ivan Gabrić.
Hello and welcome to the webinar powered by Johnson & Johnson Vision. My name is Nikica Gabrić. Today I will share our experience and talk about the premium IOL surgery. I hope you will learn from this and try to making premium IOLs bigger part of your practice. Johnson & Johnson Vision has supported our work. All the slides shown here are our experience and opinion from the implantation what we performed. The basic problem, why isn't every cataract surgeon and a premium IOL surgeon? We see that classic SWOT analysis here. Our patients don't know how, they just care about the end of result. Most older doctors are very good at what they do. When they need to try something, they remember 10 to 15 years ago, it wasn't great, so they say no. Technology is very fast. I will show you on the next slide. Young doctors are willing to try the new things, but they often don't have the skill and the experience to make sure the surgery has no complication. Like said before, technology is moving very fast. We are now on a webinar. With video and audio, something 20 years ago was impossible. I bet none of us an old Nokia and used it every day saying I don't need any better. Experience. I will be 60 years old next year, but what's kept me in the game is will to try the new things. When they presented Synergy to me, I was a little skeptical. I thought it's just one more multifocal IOL, but after trying, I changed my mind. Now, if the patient is a good candidate, Synergy is my choice. Younger doctors who work with me push me all the time to try the new technology, like the femtocataract. But we will all know to be able to do premium IOL, we need the refractive lasers too. Younger doctors have a big advantage as these machines are very computer driven. Expectation. Both young patients and young doctors are willing to try the new things. The premium IOL is a product that targets older doctors with enough cataract surgery experience and older patients who are conservative. Older patients trust their doctors more. So when the doctors believe in premium IOL, the patient will trust them. So to repeat, premium IOLs are targeting mostly wrong doctors and patients with high expectation. What is the solution? To get the solution, we need to start at the beginning. There are small moments in history that we call Eureka moments. Because this is a webinar about IOL, I will talk about the Eureka moments in cataract surgery. When people started to live longer, they got cataracts. Going back over 200 years ago, in Egypt, they tried to deal with them. About the 2nd century of the new era, they tried to vacuum aspiration. Think about it, over 1800 years ago, they were extracting lenses by vacuum. In Paris, French, Jacques Daviel invented extracapsular cataract extraction back in 1747. A British surgeon, Samuel Sharp, invented intracapsular cataract extraction with thumb expression in 1753. He was also pioneer of cataract surgery using a single knife. As people live longer, they wanted a better quality of life, so cataract surgeons were needed. One of them was John Taylor. He was personal eye surgeon to King George II, the Pope, and many European royal families. Sir Harold Ridley, I don't think that I need to say how much about him. The hard PMMA wasn't the ideal, but it was a big eureka moment. When I just was 6 years old, Dr. Kellman invented phaco. If I knew back then that man invented the device that will feed me and my family and allow me to build a chain of 7 eye clinics, I wouldn't believe it. Phaco was invention that is changing lives every minute 30 million times a year by giving people their sight back. A big often forgotten eureka moment with DL technology is the famous Mazoko Taco, the first foldable back in 1984 when I finished my medical school. My personal eureka moment happened in 1997. A young man came to my office for a follow-up after traumatic cataract surgery in Spain. He told me he could see up far and near. I didn't believe it at first, but he showed me his ability to read. I had my personal eureka moment. I knew that IOL that corrects more for one distance will change how I work. I believe in premium IOLs, so I performed bilateral cataract surgery on Ivana Trump, the first wife of Donald Trump. She had LASIK previously, and now she has Symphony Low-Ed in her eyes. I also performed the combination for Armand Assante and Franco Nero, Hollywood actors. Tim Roth and his wife Nikki, also famous Hollywood actors Sheikh Al-Qasemi, both received the Synergy IOLs. I performed premium IOL surgery on many more celebrities, politicians, and even some presidents of European countries. I think cataract and lens surgeon can be very famous, because they can bring vision back to powerful people. If they do a good job, they can become very influential. So this is a simple question. Webinars are interesting type of presentation, but if this was a classic meeting, I would ask for a show of hands now. It is easy. Who would do premium IOL surgery for their parents, partners, friends, lovers, or even yourself? My personal experience. I was myopic with astigmatic, so I had the LASIK 2006. After that, I bought a wavelight laser for my clinic. I showed that I believe in this technology. I used that as advertising and had many patients because of that. In December 2017, I had cataract surgery in my right eye. I picked the Symphony IOL as I was very happy with what my patients were getting. I had a cataract on that eye from diabetes. In May 2020, after seeing what Synergy IOL results are, I decided to have Synergy in my left eye. I didn't have any clouding in my lens. I did it show I trust technology and to compare with Symphony in my other eye. Also, I wanted to feel and see how my patients see and what they experience. If we look at the history of multifocal intraocular lens, we see that it's now over 23 years since they were introduced. But still many ophthalmologists didn't join this trend. My question for everybody here is, when did you join the trend? And if you haven't joined, why not? Like every other technology, intraocular lenses, when it started, I had some advantages and some disadvantages. With each new generation of IOL design, some disadvantages were solved. Like all technology, intraocular lenses, technology is getting better with each new generation. The problem is when you remember disadvantages of all technology. Now a reminder about the SWOT analysis from the beginning, that Nokia phone. It is now 23 years old. Why do doctors think that phones, computers, and cars are better now, but multifocal IOLs are the same? If the whole technology of the phones was dependent of older doctors, it wouldn't never advance to the standard. But young people accepted the new technology and made older people to have to accept it. I implanted my first multifocal IOL back in 1999. Since then, I implanted over 12,000 multifocal IOLs. I have tried every IOL on the planet, from the yearly array to the new Symphony and Synergy IOLs. My center was a study center for both Symphony and Synergy. We all know multifocals are great for the near and distance, or phone and driving. Trifocal was okay for driving, okay for computer, okay, and for near okay. But there are always these gaps and people keep hunting for the focus. With every new generation, we get something better. I often tell my patient that multifocal are compromised, had to pick the compromise based on what they do. You would never put the same IOL into the pilot and a dentist. Always think about what they do and what they need. As we live longer, we want to live better. We are active a lot more than any other time in history. That is why presbyopia correction is the holy grail of refractive surgery. There were never more old rich people wanting to live life better than now. They want to use phones, tablets, computers like young people. They don't like to have 3 sets of glasses. Also, they are willing to pay a premium price for their independence. Low light restaurants, tablets, driving, golf, a big disadvantage for older generation of intraocular lenses are what these people want to us to solve for them. With Synergy, in my opinion, we are in a eureka moment again. Synergy is offering continuous range of vision. There are no gaps like with trifocal or multifocal generation. The low light performance of Synergy is amazing and it's a very important for our patient. And now for your eureka moment. What do you need to be a premium IOL surgeon? I can tell you exactly, but I can show you how I became one. In my 7 centers, we do more than 4,800 lens surgery per year. 1,600 of them are multifocals. Just think about it, we in Eastern Europe, where people aren't very rich, do so many premium IOLs. Although similar, the cataract surgeon and premium IOL surgeon are not the same person. The cataract surgeon has 20 happy patients. These patients are not as demanding as the surgery has a different goal. The premium IOL surgeon has extremely high expectation from the patient. They want quick recovery, perfect vision, and no residual refractive error. The exam for the premium IOL patient is very detailed. It must include a special focus on talking to the patient about their needs and the pros and cons of premium IOL technology. Picking the right patient is very important. They need to have the high motivation. They need to understand the limits. Most importantly, what is they will get. This is very important. If they are unhappy, you need to remind them about what they gained and what they lost. You need to have the best technology to exclude bad candidates. You also need great technology to deliver these results. Patients love getting their colorful reports showing their eyes and results. Offering premium IOLs without offering femtocataract is possible, but your competition will drive sales away when they get the machine, and you will need to catch up instead of leading the way. Never think you don't need to think about the cylinder. The residual cylinder is horrible and will make a good premium IOL surgery into the hell for you and the patient. manage the cylinder by toric lens, by lumbar relaxing incision, or by laser, but don't think that is not important. Always position the incision on steep meridian. You need to be ready for refractive surprise and any other issue with premium IOLs. You need to solve these problems quick and no cost for the patient. It is important to start with easy patient, no cylinder and refractive error from before. Hyperops are easy because they get a big wow effect. Myopia over 3 diopters is also very easy because they also have a wow effect. When you get experience, then you started doing plano presbyopia. Before synergy, I used do mix and match like this. I would put in dominant eye with a small myopia, non-dominant eye, and minus 0.5 myopia target. Later, I did dominant eye always symphony with very small myopia less than 0.3 diopters. Non-dominant eye, if the patient is below 65, I would put the low end plus 2.75. When the patient is over 65, I would put low end plus 3.25. Now with synergy, we don't have to do mix and match anymore. We don't have to wait for the distance visual acuity to drop. We don't have to start the consultation with what they will lose in contrast and distance. We don't have to warn about the low light. And the real eureka for me, we don't have to turn away the plano presbyop anymore. Johnson & Johnson will show you this defocus curve and you will say it is too good to be true. So we did post-market study for synergy and made 206 defocus curve measurements. The defocus curve we measured was actually even a little bit better than the Johnson & Johnson promise. It's really amazing. We use a lot of testing for synergy as we do every other premium IOL. We use IOL Master 700 and the Barrett Universal 2 formula. We use the recommended 119.3 R constant, and in over 800 implantation we don't have any issue. Our experience with synergy is now at 800 implantation, but my son Ivan, a resident of ophthalmology, will share the results from the study.
Thank you very much. As my father said, I will share the results from the study, but he was the one who was doing the implantations. Professor Gabrić, Professor Decaric, Dr. Barišić were the people who were implanting most of the lenses, and he personally has implanted over 500, and including one in his own eye. The second thing is, our first implantation was about 1 year ago on May 29th, 2019. The 95th is important because it was just before we were in Paris, where we presented the first results. And right now we are at 800 implantations. Unfortunately, because of COVID-19, we didn't do our 1,000th implantation, but if there wasn't COVID-19, we would be over 1,100. It's strange to say, but Synergy is now a super premium IOL, because before Symphony was the premium IOL, and it still has some position, but what do you call something better than premium? Super premium. So on the other side, as it was mentioned in the introduction, we have done surgery on 420 patients so far, which is 800 eyes. And what is important is, if you look at that number, you can see that almost all of them are bilateral cataract surgery, same day, at the same time. It is a lot easier for multifocal patients to adapt when they have both eyes done at the same time. Because if you separate it, like in standard cataract surgery, they will adjust for one eye and then for the other eye. The also important thing is, we have done it to very young people, as young as 33 years of age with traumatic cataracts. We have done it, although Johnson & Johnson will say that it's not instruction for use, but we have done it in post-LASIK patients, including my father here. What we will present here is, and I hope that Rafael Guerrero from the post-market team in Johnson & Johnson is on the call. Right now we are finishing the largest study group of Synergy patients with over 103 implantations, 103 patients with 206 implantations, with a follow-up of 3 months, where we have analyzed their in data, out data, and the results are so good that we were warned that journals will say that it's impossible. So a large part of this discussion will be about patient selection. What my father mentioned before, and that is, you have to pick the highly motivated patient. The patient has to say, I want this. There is a difference. You can manipulate people or you can convince people. The problem is, when you manipulate someone, you're doing something that you want them to do, and that's not good. Because we did surgery on so many high-profile people and so many normal people. People come to our office saying, I want the type of surgery my friend had, I want the type of surgery my neighbor had, I want the type of surgery even a Trump had. But they're not coming as standard cataract patients who we then try to convert to premium patients. No, they're already coming and saying, oh, I don't want reading glasses. I don't want to have one glasses for reading. I don't want progressive glasses. They're coming to us asking us for a solution. And this is the most important part in patient selection, because this is from the Cataract Questionnaire that was a part of the study. We asked the patients 9 specific questions about their life right now, before surgery and after surgery. So we were evaluating, can they read newspapers? Can they play sports? Can they do things with their hands? And they couldn't. Most of the people are young. In the study, the average age was 56. So you're taking someone who's a lawyer, who's maybe a doctor, maybe a dentist, maybe a pilot. And they work. They can't afford downtime, and they want a solution. The score at the end is basically 100% satisfaction, because these people came with a problem. The problem was, I don't want reading glasses. The solution is Synergy. So even those slight problems that, or not even problems, but maybe some small things like halos or glare, they know that they will exist because it's a compromise. But the liberty they get, the ability to read, is so good that these little things, then they don't matter. And this is why patient selection is so important. The notes that we want to share with you: all of the patients are very satisfied with distance, intermediate, and near vision. There are no gaps like with classic multifocal lenses. It's really true that the focus curve that I measured and that Johnson is showing you is true. You can go to any distance, there are no gaps. All of the patients read at least J2. Before, you would have to do mix and match with some myopization with one eye, other eye to mix and match it. With Synergy, they will all read J2 or better. Most people read J1, and some people even read J1 plus. As I said before, I'm 31 years old. Sometimes when I have Synergy patients, they read so well the small letters on the pocket chart, it's a good thing I know them by heart, so I don't need to read with them. We also did a special study within this group of low light reading. We used a special light meter to make sure that the room is dark to the same standard, and they could read J2 or better in the dark. And again, I'm 31, sometimes it was hard for me to read, and this was an often big issue for some patients who would say, I can't read in restaurants, I can't read in church. So with Synergy, we don't get these complaints. We have also done some patients with a mix of Synergy and Symphony, including my father here. So he has Symphony in one eye and Synergy in the other. They do notice a slight difference, especially because there is a difference in color. The Synergy colors are a little bit different, but the quality of vision for the range makes up for the difference in distance and color, but it's non-noticeable. If they had to pick one eye, they would always pick the Synergy eye because it gives them more freedom. We have also done a combination where we put Synergy in one eye and panoptics in the other eye. The panoptics eye was always worse. They did not like the picture. The color rendering was too yellow, and we had slight dissatisfaction with that. Again, as Johnson & Johnson will say, Synergy is not meant for post-LASIK eyes. We have done it. It depends on your own personal experience and the amount of risk you're willing to take. But all of them are very happy, again, including my father, who had myopic LASIK and has Synergy and Symphony with no issues. The PCO rate is about the same as with other Tecnis IOLs, but we noticed that Synergy patients are a little bit more sensitive to PCO, meaning that even small amounts of PCO, they will report it. Unlike with Symphony or LOAD, they will tolerate some amount. But again, it's a non-issue because the percentage is very low. And in conclusion, the IOL is very promising. Right now, after 800 implantations, that means that Synergy is about 50% of our premium segment, because some of the centers don't have the buying power to go with Synergy. But we are transitioning almost entirely to offering Synergy to every patient that is a good candidate. The patients are very happy with distance, intermediate, and near vision. They report amazing results in low light conditions. It is very easy to calculate. There are no tricks at all. Just look at the Barrett universal formula, pick the IOL that's closest to emetropia or a little bit above the plus, and that's it. Minimal positive and negative dysphotopsia are reported. Out of the 206 analyzed eyes, only 2 complained, and when asked to grade it from 1 to 5, they would say 1 or 2. So we had 0 explantations on 800 eyes because of anything. And the contrast sensitivity is also very good, especially when compared to other earlier generation IOLs. So at the beginning, my father presented a problem. How do you become a premium IOL surgeon? It starts with you. You're the doctor. You need to believe in this new technology. To show that you believe, you and everyone in your team have to be without glasses. You cannot be wearing glasses around the office saying to your patients, presbyopia correcting IOLs are a great idea. And they will ask, but doctor, why are you in glasses? So you really have to believe it. The best way to do it is try it for yourself, do it for everyone in your team. We have done Synergy to some surgical staff, to some of our doctors. If you're a candidate, why not? We will never offer something that we are unwilling to do to ourselves. My father did LASIK to me. So again, first-hand experience is the most important thing. And this is what we're offering. Everyone here on this webinar, everyone in general, you are free to come to our office. You can come and see the patients on their surgery day, but you have to stay for the next day for the post-op to see them the next morning reading 100% distance and J1. Once you see it a few times and it becomes normal for you, you will start trusting into this technology. What you need to be able is to offer the whole range of services to patients. If you can't offer everything, then you're willing to do a compromise. The compromises will deliver results which will keep your patients unhappy, and they will make you feel uneasy. So if you look at this chart, it's a flow chart. Match the patient, the doctor, and the procedure. If they're young and healthy cornea, do femtolase. If they're young, healthy cornea, but a little bit thin, PRK is the choice. If the prescription is very high, you can do an ICL. If they are older and the predicted post-op cylinder is less than 1, you can do Synergy. If they're older and they have a bigger cylinder, we do prefer the Toric trifocal platform because it's more stable. There's no rotation in the eye. If they're older and have some other conditions that don't allow for a high-end lens like Synergy, or they had LASIK before, you can always go with iHands. It is an amazing lens which has delivered great results for us. And at the end, if there is any sort of an issue with any patient, you have to be willing to do to remove the refractive error at no cost to the patient using excimer laser or some other technology. The key is find the right procedure for the right patient. Don't do compromises, don't do monovisions, LASIKs for 40 plus. Pick Synergy. for plano presbyopia. You will be happy. And at the end, we would very much like to thank everyone from Johnson & Johnson for making this happen and for you all joining us. And as we said before, you are all welcome to come to our center to see how we work. Stay as long as you want. And there's another offer. Any ophthalmologist anywhere on the planet, if they're willing to undergo premium IOL surgery, will get that from us for free. And that's a standing offer all the time. If they need LASIK, we'll do that as well, because we want to share this experience. Thank you.
Thank you very much.
Professor Gabrić, thank you, Dr. Gabrić. That was a really impressive presentation and so much to learn on the premium business and also on the PCIOL. And it's a pity in these webinars you don't hear anything directly from the audience, because if that was a really face-to-face meeting, there would be a loud, super loud applause now from all the audience here. But well, imagine they clap all their hands now. So really great. Thank you so much. And of course, we received a couple of questions that we'd like now to address and would kindly ask you to respond to those. So you mentioned, I think, 2 times in your presentation the example of a dentist and a pilot. And according to that, we received a question from a participant. What type of IOL would you recommend for the dentist?
Okay, we will start from the last one question. For example, for pilot, I will do the synergy for both eyes, but for dentist, I will put for him in the non-dominant eye low ed plus 35, dominant eye synergy, and non-dominant eye low ed plus 3.25. Why? Because the dentist need to see very, very small detail, and he have to have the magnification. The second question, do you see the color contrast difference in the Symphony and Synergy? I have to tell you that Symphony, the Synergy, I have the better vision, continuous vision, but it's a little yellow picture. And for example, if I look in the portrait of my parents, which is my office, I can see a little bit contrast sensitivity diminish on the left eye, but with Symphony I can see easier to contrast sensitivity is a little bit better. But Symphony picture is 10% is bigger than Synergy. But when I look with both eyes, it's perfect vision. But I prefer left eye for the reading. I have to tell you, I operated more than 2,000 cataract surgery in a year, and I cannot see any halo glare in the microscope. I polishing my capsule like anybody, try to remove everything, but I never seen halo glare. I can see halo during the neodymium YAG laser if I have too bright reflex and red point, little bit see about the red colors. But I'd like to drive very fast. I don't tell how much in the night, how fast I drive. It's horrible, but I never seen the halo and glare. I have to concentrate to see the halo. It's a question what you want to be. Do you want to be the part of solution, or do you want to be the part of the problem? If you decided to be the part of the problem, you will have the glare and halo. But it's a very small. For example, during the traffic lights, you can see when you look in the red light, you can see when I concentrated, you can see the cycle. Less cycle you can see on the yellow, but don't see the green. But if you look what people from Germany, Professor Raufar, show, it's not true that you can see on every light every cycle. It's not true. And I past several days, I didn't see the notice. When I'm a little bit tired, I can see the small glare. And first question, do you consider the refractive lens exchange in patient advantage versus LASIK? For example, if I have the person who has the +6, +7, +5 and 35 years, I prefer the refractive lens exchange, and people are very satisfied. I have to tell you that I perform more than 10 patients with bus drivers. They are amazing with this new vision. They notice small glare, small disturbance during the night vision. They rebuild.
They're reborn.
They're reborn. They are
Especially
reborn.
hyperopes. The most happy hyperopic patients, they will be ecstatic. Ovo smo riješili, ovo šta mislimo o akomodativnim lećama I novim lećama.
More into the future, what would be your expectation for if there's any benefit from new designs that may come up like accommodative lenses? Do you think so?
Akomodativne leće koje same.
I have no experience with accommodative lens, and I cannot tell you about it. I have no experience with this, but all kind of multifocal lenses, what I noticed in the lecture, I have experience, and I have to tell you the Zeiss Toric is very good lenses, very good optics, but PCO rate is more than 20%.
Šta ako implantiramo synergy in reverse? To ja znam. So if you implant the synergy lens in reverse, I actually asked that question from them. They say there shouldn't be a difference, but I'm not sure. Johnson & Johnson, their development team would probably know, but some IOL designs are not able to be reversed, and we have not had such a situation here yet. So I think you should ask your Johnson & Johnson representative for that. And here we have one. Which premium IOL would we recommend to a cataract surgeon?
I prefer the synergy for both eyes. I think that is the best intraocular lenses on the market today. The next question is, how do you have experience implanting synergy post PRK? I had the LASIK 12 years ago and performed with my eyes the synergy. It's depending about what's the optical zone is created on the eye. It's depending how you use the optical zone. If the small optical zone, it is not good to perform the synergy, or the centrated optical zone, it's not good. It's better to perform eye-hands lenses. It's a very good lenses. I created eye-hands lenses for people which doesn't know enough about these lenses. It's a lenses with extended range of vision. It's a plus 0.5. I prepare this type of surgery like the people which wear the contact lenses. Small myopization for the distance vision. It's a 0.5, minus 0.5. It's not take the distance vision and prepare for them for near vision. It's excellent combination.
Šta sa zonularnom nestabilnom? Da li stavljaš ring?
What do we approach for the patient with zonal instability? Of course, I perform the zonular ring. It's normal, like in other cataract. 45 years.
Classic.
I think we have to do that. That's a long question to read and really specific. So it's about really a case of a 45-year-old patient, post LASIK, and now it's disappearing, with minimal cataract and myopia, and in both eyes, and this.
Positive.
It's my case. I had myopic and astigmatic oblique oblique astigmatism, and I left to my eyes 0.75 for both eyes. And they calculated the symphony for 0.5. And I get it, the small cylinder on the right eye and small minus 0.5 cylinder on the right eye. But when I look with both eyes, I can see 1.0 on distance vision, and I can see with 60 years old one Jagger 1 Plus.
So we had two questions on different lenses. So one is about your experience with panoptics, because you mentioned before that you had, in comparison to Synergy, a few panoptics patients.
Panoptics is very good lenses, but it's a trifocal lenses, and people can see the gaps between the distance and intermediate, and gaps from intermediate to near vision. It's sometimes difficult to patient to accept these small gaps between this range. For example, they told me I have to put my side to the computer to see what happened. It's not possible to see on the distance. I can see from this position every small letters on computers.
The unusual combination would be Synergy, Tecnis Synergy and Tecnis eye hands.
I experimentize with this. For example, I think that maybe it also excellent combination. Eye hands for a dominant eye and for non-dominant eye in the Synergy. I do this type of surgery in 10 cases when I have some problems with amblyopia, with keratoconus early stage. I put on this eye hands, and the second eye I put the Synergy.
Nice.
Catalyst is very promising technology. I took this equipment for my sons. I can do the surgery faster than Catalyst. I need only 5 minutes for one eye, and I operated five cases per hour. It's a 10 cases for 2 hours. But when I measure time, what I need for the catalyst and for whole operation, I need about 15 to 17 minutes to finish one eye. It's a very good equipment for the young surgeon, because we make the shortcut in the curve of learning of education, and it will be for them most easier to perform the surgery.
What we see quite often is about the usage of auto-refractometer, what actually we as a company do not recommend. What's your experience on that? And also with the maximum plus technique.
Znači, question is
do we use the autorefractometer nakon multifokala? Ne.
Ma koje gledaju ovo?
Ne, ovo.
We can use the autorefractometer, but it's oriented
so orientational purposes only.
For orientation for result. The second question is, after vitrectomy, would I implant it Synergy or eye hands? I prefer eye hands for the Synergy. Or macular disorder, pathology, or something what can
so any problem
with posterior segment, I will perform the eye hands lenses. Do anything different pre-operative power selection to patient post-LASIK? Post-LASIK patient, it's a depending what kind of laser surgery performed before. If you have the wide optical zone, it's a good. It's a if it's optical zone decentrated, unregular, or not any residual cylinder, it's better to use two eye hands.
So when we calculate, we use the ASCRS calculator, but the Barrett Universal post-LASIK calculator in the UL Master is good. Da vam kažemo da će biti 100% glasses free.
To the question, what kind of target refraction you are aiming for?
I perform binocular surgery. I will tell them that 99% I can be sure that will be 0.5. I cannot guarantee 100%, but I can guarantee 99% because for example, if you need, Johnson & Johnson suggested us to work only one cylinder. I can escape more than 1.5 cylinder. For example, I always go to the steepest meridian, and from time to time I need to perform with both incision. For example, 12 o'clock and 6 o'clock incision. I always use 2.75 knives. It's not necessary to use 1.8 or 2.2. If you want to decrease the cylinder, you should relax the steepest meridian. It's a very important. If I not achieve that, I also perform the lumbar relaxing incision for 2 quadrants or half, 1/3 of the cornea on both sides of the eye. I targeting on EL Master. I use the Barrett Universal 2 formula and always gain the first plus after emetropia. Of course, I use the topography, and it's important for me. I always look in topography where is the steepest meridian.
So in between, I also received a question by WhatsApp from a participant who is asking, I think more for Dr. Gabrić, we're talking about the 9-question questionnaire that you're using as a standard for your pre-op exams. Who's doing this?
No, so that was the questionnaire only for the study. We don't do a normal questionnaire. It's about patient counseling. So when the patient arrives, you first talk to them about what they do, what they use their eyes for, how do they work, what's important for them. So that's how we go about. The second thing is, the question there was, do we use the K values from the topographer or the keratographer? We have tried multiple approaches, and what we found is if you use the IOL Master 700, the true K from that is good enough. Before, sometimes we would use the K values from the Pentacam or a similar device.
I prefer. I'd like to perform 5.5 millimeters. I can do by the forceps, by the needle, and by the femtocataract. It's easy for me. Do you recommendation patient cataract with macular edema and retinitis pigmentosa? When you have the retinitis pigmentosa, you can use eye-hands lenses or aspheric lenses, but if you have the macular edema, you have to treat it first macular edema with the anti-VEGF and maybe later peeling membrana interior, vitrectomy, and so on. It's not good for the synergy. It's better to use the eye-hands or aspheric lenses.
Even a question in
formula for synergy. I told yet it's best calculated for us. R constant 119.3. We use the Barrett formula. If you have biggest hyperopia, we use also.
We use the closest to emetropia. In very high hyperopes, we don't look for the first plus. We look to what's the nearest to emetropia, because in those very short eyes, it's so easy to go too much to plus.
No more questions?
Do you see anything? No, I think we covered the Croatian one. Was the last one, no? That you
covered the last one, the one in Croatian. It was about the formula. And we did this, what's the preferred size, And we said we don't tell them they will be 100% free. We told them 99.
Mention also in your presentation that there's still some room for Symphony in your clinic. Are the patients that are, what are these patients that you
I can do the Symphony for the patient also, for example, from other part of the region. I use in 7 centers in Croatia, in Bosnia, in Macedonia, in Serbia, and if they don't have enough money or it's a price for the synergy too high, I perform mix and match in this country. Also try to perform the Symphony in small myopia and low ed 2.75 because the price is a little bit less than the synergy price.
Question in Croatian, I think so.
Yes, do I use the synergy on the high myopes? It's for example, I can do -10. We have the lenses. It's about +5, +6 lenses what we implanted in the eye.
And they're okay. They're very happy.
But we have to examine very carefully patient. Does the patient has any degeneration of the periphery on the posterior segment? And if you have, we perform the laser and very carefully examine the posterior segment.
Hey, thank you very much. One last question. So for those surgeons that now think after all what they learned, they want to start with premium, they want to start with PCIOL, what would be the first step to go?
Oh, what's the first step to start with presbyopia PCIOLs? Yourself.
The best start is a better education. The most problem is education. For example, 30 years ago, I forbidden to nurses to assist the doctors. The resident have to assist to doctors. In my operating theaters, you cannot see nurses that assisted to doctors. It's not possible. Young doctors have to learn from the earlier doctors. There are 2 screens in every operating theater. There are several screens in the library. Young people has to work and see how surgery looks. For example, pilots in United States Air Force are between the 20 and 35 years age. These fighter jets cost $100 million. Why all doctors think that young doctors cannot do fake or lazy? This machine costs that $50,000. If you compare with aircraft, it's 100 million. It's a privilege of elder doctors. They keep their position. I have 70 doctors which work for me, and I'm interested in to educate them. I can't believe that it's not possible, but everybody has to deserve own position. It's a quite different education.
Yeah. There came 2 more questions before we close. I think we are already a bit 7 o'clock. I think comes speculation comes after synergy. With improvements. Synergy toric. So as one improvement, of course, there will be synergy toric that will come.
We will expect it, the synergy toric.
That will come, yeah.
But I think that is Johnson & Johnson has to improve the haptic. I saw a lot of cases with Symphony and all other Tecnis toric lenses. When you have the biggest eye or myopic eye, every lens is will rotated. You will put it on the right axis, and for 10 days you will get a 20-30 degree movement. The compromise what I find is the excellent position of the size toric, but size toric has a lot of PCO, more than 20% in 1 year.
The
Barrett formula. Are you using that?
So for the Barrett formula, we use the lens factor of 2.09.
Can you use an H patient which patient? I will do the eye-hands when you have the when you have the pterygium, but I will move the pterygium in the same act.
Specific question. So we have a bit past 7 o'clock. We really made it. You answered so many questions and you gave so many advice and shared so much of your experience. So thank you very much, Professor Gabrić. Thank you very much, Dr. Gabrić. That was really great. The presentation, but also the discussion, I think very, very helpful for all the participants here. And so thank you very much for all this. And I can just repeat, really great. And thank you so much. For further webinars of that platform that Gerald Erbe mentioned at the beginning of the introduction, we will publish details on these on the website www.surgicalvisionacademy.com. Of course, would also be interested to learn from you, from your participants' view on that webinar. So we would all of you ask to stay connected here on that website and take a few minutes of your time to complete the brief feedback questionnaire that will be displayed on your screen. So thank you very much for all of you for your participation. And again, thank you very much, Professor Gabrić and Dr. Gabrić, for these great learnings and great presentations and for your time and availability for that webinar. Thank you so much, very much. Thank you.
Thank you. Have a nice day.